We'll just give everyone 30 seconds to join and then we'll get started.
Okay. Yeah. Wait, that's too quiet now.
What?
Isn't that too quiet now?
Too quiet.
Yeah. Yeah.
Is this better? Yeah, I'm gonna say like.
I think it's like it's like
Oh.
Okay, looks like a few people are still joining, but we can get started. Hi, everyone. Thank you so much for joining us tonight. My name's Robin Fennell. I'm the brand manager for Revenas here at Prollenium. I'm excited to be your host for today's webinar focused on technique-driven sessions and lip mastery by Heather Zade. Today's webinar is all about elevating your lip injection technique while enhancing overall lower face balance. Heather will be walking us through what sets Revenas lips apart, including unique properties that support controlled placement and natural-looking treatment outcomes. She'll share practical techniques with us today for treating different lip types, discuss strategies for creating lip harmony and within the lower face, and review adverse event protocol to ensure that you're injecting with both confidence and safety. Whether you're newer to lip injection techniques or looking to refine and elevate your results, this session's designed to deliver actionable insights that you can take away and bring directly into your practice. Based on the registration and attendance, I don't think Heather requires an introduction, but we're thrilled to have Heather Zade leading today's discussion. Heather is the founder and CEO of Adora Aesthetics and a board-certified nurse practitioner with over 16 years of injecting experience. She's widely recognized for delivering natural, beautiful results and has trained extensively across the country. Today, she educates injectors around the world and has been named a top 100 injector in the nation for the past 3 consecutive years. As a national trainer and speaker who has trained thousands of injectors and as founder of Adora Academy, Heather brings a wealth of clinical experience, technical precision, and a true passion for education to everything she does. Before we begin, just a few quick housekeeping notes. You can use the Zoom webinar controls however you'd like to personalize it. Today's format is 45 minutes of Heather's presentation, and then we'll have 15 minutes of Q&A at the end. Please feel free to submit questions throughout, but we will be holding questions until the end, and then aiming to address as many as possible at the end of the session. Our medical affairs team is moderating them throughout, so if there are any we aren't able to answer, you can reach out directly to Prollenium Medical Affairs afterwards. If at any time there's a technical glitch, please just rejoin using the same link. With that, it's my pleasure to introduce Heather Zade. Heather, thank you for being here. I'll turn it over to you.
Thank you, Robin. Hi, everyone. I'm so happy to be here tonight. I know that everyone has probably had a long day of seeing clients and having busy lives, so thank you for coming tonight. I have poured a ton of information into this webinar. I have poured my heart and soul into this. I tried to give you guys as much information as I possibly could give you in 45 minutes. So I'm going to go quickly through a lot of this. And if you have questions, please type them in and I will answer as many as I can at the end of this. All right, so let's get started. Before I start, I have to disclose a couple things. I am a trainer and speaker for Prollenium and MERS. I do own a training academy called Adora Academy, which is in Maryland, and we do receive grants that are sponsored. The technique you're learning tonight is trademarked and patent pending. If you don't know who I am, my name is Heather Zade. I am a nurse practitioner and I own Adora Aesthetics, which is a med spa in Columbia, Maryland, Clarksville, Maryland. We have another location as well, and it's been a long journey to get here. I could talk about myself for hours, but I'm not going to tonight. So I'm going to keep going with the presentation. So before we get into all of the nitty-gritty having to do with lips, I want to first talk about assessment and consultation very quickly. I always think it's interesting to talk about consultation because it's a huge part of what we do and it sets the tone for your whole relationship with your client. So I think it's interesting when a patient comes in and they have lips, as you see on the left of your screen, and their inspo picture is the lips on the right of the screen. So we immediately know there's going to be so much education involved. What changes do the patients desire? Are they realistic? Do they even understand that the picture on the right is completely photoshopped? How many sessions are going to be needed? And it's going to gauge the whole discussion about the process of lip filler. So it's really important to make sure that they are on board and have realistic expectations. So why are we doing this anyway, right? So our patients come in for lip filler because they want to increase their self-confidence. They might desire a certain lip shape or volume. They want to feel more attractive and comfortable in their own skin. They want to improve their body image. They want to enhance their facial harmony. They want to improve positive psychological impact also. So we know that when you look good, you feel good. It improves their self-esteem, improved mood, and a more positive outlook on life. So what are we aiming for? Obviously, we're aiming for something called the perfect lip. I like to say that what I try to do is create a perfect lip for that patient. I don't really believe that there is an actual perfect lip. I think it has to match the patient's face, and we need to be looking at full facial harmony rather than just looking at a lip. Sometimes a lip can look perfect, but if it's not balanced to the face, we're going to do them more harm than good. The classic golden ratio that you've heard of is the bottom lip should be 1.618 times larger than the top lip, and the top lip should protrude 1.618 times more forward than the bottom lip when you're looking at the side. I think people forget that when they're injecting, when they're just looking at the one view of the patient. And you have to remember, if you close your mouth, your top teeth are resting in front of your bottom teeth. So the top lip should protrude out a little bit more, and everyone tries to kind of fill the bottom lip. So always remember that that's how we're made. That's how our anatomy is. And the lip should be 1.618 times wider than the nose as well. And these are things that you can measure. You can get a caliber, you can measure it and explain it to the patient as well. So I think more so now in modern day, more people are looking at this modern lip ratio. I like to call this 1-to-1 ratio the more modern lip. You can see on the left, those are actually Angelina Jolie's lips. That's that classic lip ratio for beautification, the 1 to 1.6. More and more patients are coming in looking for a 1-to-1 ratio. I prefer this on a lot of my patients, but again, you have to make sure it matches their face and what's going to look better for them. So here's another picture of your ideal lip projection. You can measure this. These are all things that everyone should kind of keep in mind when they're injecting. So the top lip should extend no more than 3.5 millimeters, and the bottom lip should extend no more than 2.2 millimeters. So just keep these numbers in mind and try not to go over them. That's when the patient's going to start to look overfilled and fake and not as pretty as it can look. I think this is funny. My kids actually brought something like this home from school, and it made me think about what we do daily in our practice. So we inject lips. A lot of people forget that lips are usually never just in this static position. Lips are always moving. So all these different sounds and words that we make, smiling, neutral, angry, sad. And when we make our different sounds like A, E, I, O, U, B, M, P, F, V, you can look at the chart. I think it's funny. The lips make different motions. They're always in motions. They're never static, really. So when you're filling a lip, keep in mind that they also need to look cohesive when the patient is speaking. So when you're done injecting or even in the middle of injecting, I like to talk to my patient. I usually ask them what they're doing that evening, what they're doing that weekend. Do they have any events coming up? I just want to see what they look like when they're answering a question naturally. And you want to make sure that the lips look good when they're moving, not just for your after picture. All right, so we're going to jump into anatomy. So the lip has 3 upper tubercles and 2 lower tubercles. Superficial anatomy that you need to know, we have the philtrum column, we have the wet-dry border, we have our oral commissures at the side of the mouth, we have our vermilion border, the vermilion lip, and our Cupid's bow. Getting into zones and segments of the lip. So there are lip segments and there are lip zones. And these are things that we have to remember when we're filling a lip. One segment can affect a different segment, and a zone can affect all of the segments put together. So this is something a little different. Not everyone kind of looks at this, but I'm going to read through this. You can take a picture of this if you want. But the lips can be divided into 5 different segments, and that reflects the natural plane of the lips. So your upper lip has 3 sections, which are shaped by the philtrum and tapered planes. And then the lower lip has 2 sections, which form a teardrop shape like a ball and tail structure. So when you assess the patient, you want to have them open their mouth slightly, and then these become reference points for the lips. And then lip zones that you see on the right side of the screen, we have zone A, zone B, and then zone C you can see in the middle of the mouth. We typically don't enhance this part of the mouth, usually unless we are treating an M-shaped lip. Sometimes we'll inject more into that wet dry border, which we'll show you in a little bit. But zone A and B are going to influence how the line between the lips presents. And we know that that line between the lips, we want to look a little bit more flat. So in an M shape, which we're going to get into in a little bit, we have curvature of the lips in that wet dry border. And the goal is to more so flatten that out. So keep this in mind. Each zone affects each other, and they can, you know, change how the lip is going to turn out if you don't pay attention to all the zones and how they're going to affect each other. Okay, so we're going to get into a little more deeper anatomy. So we know the muscle around the lips is a sphincter muscle. And now we know through cadaver and MRI studies that the sphincter isn't just actually circular. It's layered and it has radial fibers that interlace and it has elevators and depressors. So again, it kind of goes back to what my kids are learning in preschool. The mouth is always moving. We're always making different motions. It's not just this plain circle. It's a lot to it. All right, so the muscles that affect the lips, we have the zygomaticus minor and major, and we have our masseter muscles. I like this kind of 2 different views so you can see what they look like from the side, and then you can see what they look like from the front and where they are on the face. I'm going to go through this fast. I could take a full day talking about anatomy, but these are just different areas that you need to make sure you know when you're injecting the face and especially the lips. So the orbicularis oris is the primary lip muscle, which includes deep and superficial fibers. Your zygomaticus major and minor is going to be what elevates the lips and affects your smile height. And then your levator labii superioris is what controls your upper lip movement and can contribute to the gummy smiles. You have your depressor labii inferioris and the mentalis, which are going to influence the lip downturning and the chin dimpling. I love this picture. I actually show this in tons of my classes that we do. This is my favorite picture I've ever found of the labial arteries. It's from a cadaver dissection. They injected dye so that you can see them a little bit better, but it's just very, very clear. So you can see the facial artery coming up the face, and then you can see where the inferior labial artery and the superior labial artery branch off. And you can see that in this one, they are deep, they're underneath the muscle. So I like that picture. So keep that one in your head when you're injecting. Here's another view of the superior labial artery. I like this one because you can see they're taking the lip and actually folding it right over, and you can see how deep this one is on this cadaver also. So it's going to branch, your blood supply is going to come to the upper lip, the mucosal, and the nose as well. So I always say when you're injecting and you're looking for blood flow, you're not just looking at the lip, you're looking all around the mouth, and you're looking all the way up to the nose, the glabella. You want to check blood flow throughout the whole face while you're injecting for safety reasons. It's going to originate about 1 centimeter from the oral commissure, and the mean diameter is 1.8 millimeters. Now we have our inferior labial artery. You can see the bottom picture. This is like your textbook classic picture you're going to see in every lecture you do. I feel like it tells you what they are, but it doesn't explain anything because it doesn't show you any depth. So I showed you a cadaver dissection right on top of it that I tried to match it. So you can see on a real human where these arteries actually are. So you can see your superior and inferior labial artery. It shows the depth of them. I love this picture. But your inferior artery is going to supply blood to the lower lip and chin, and the mean diameter is smaller, 1 millimeter plus or minus about 0.3 millimeters. Okay, and then there's 3 different distribution patterns of the superior and inferior labial artery. So I know everyone always thinks it's deep, deep, deep. Yes, about almost 80% of the time it is deep. So there's 3 different areas that it can be in. So 1, it can be submucosal between the muscle and the oral mucosa. That's 78.1%. It can be intramuscular. People think that it can't be in the muscle, but in 17.5% of patients, it is in the muscle. So that's going to be between the superficial and deep layers of the muscle. And then 3, it can be subcutaneous, only 2%, but it can happen. So that's why people think they're always safe when they're superficial. You're never always safe. So 2% of patients do have the arteries going through the subcutaneous layer, which is going to be between the skin and the muscle. This is a cadaver dissection of the lip. This was taken live. I love showing this. If you get grossed out, you can turn this off for about 30 more seconds. So here's your skin over the lip. We're pulling down the lip. You can see here the facial artery where it cuts off across into the superior labial artery. Now I paused the screen so I can point out to you where these arteries are if you're getting confused looking at this. But what you can see where the superior labial artery is, underneath that is the teeth. So if they flip that over, you would see the top teeth. So you have your superior labial artery, the angular artery that's going to go up by your nose, and then where the facial artery splits. So we'll keep watching this for a second just so you can keep getting a good view of this. You can see this is one that's a little more deep, but there we go. When we fold it over, you can really see. Usually when I start injecting, I'll pop the lip over like that and see if you can see any arteries pulsing. Sometimes you can. So I think that's just a cool video for you guys to see. All right, we're going to get right into technique here. So my lip technique, it's interesting. So 2 years ago, a little over 2 years ago, I did my first webinar for Prollenium. That's when we had introduced the lip technique, which is a bolus technique. It's 3 to 7 injection points. And I am still doing that technique to this day. I've changed it a little bit just in that I'm injecting more medial than lateral now, which I'll show you in the videos. I have 3 live injection videos that we took to play for you tonight. So we'll get into that. But we're going to show more difficult lip shapes, where the first webinar we did, which I think you can probably still get access to, is just the technique. All right. Here's your main injection techniques that you'll learn about. So we know we have the linear technique, we have tenting technique, micro droplet, and vermilion border technique. This is my technique. It's a little bit confusing on this screen. For about 50% of patients, I only do 3 pokes. So I'm going to explain these to you because this is kind of the basis of all of the videos that you're going to see. Even M-shaped lips and thin lips and older lips, I start with the same process for each lip, and then I'll go in and tweak them. The only difference between a younger and an older lip or a thin lip is that I take away the bolus. So I do the same exact procedure, but there's no bolusing. The bolus is what's going to give you that height. It's going to give you a little bit more drama, more juiciness, if you will. So into the technique. So the first injection point you're going to see here is the 1. So I'm going to inject into the Cupid's bow. I'm going to keep it pretty superficial. The way that you know you're in the right depth is if the patient's laying flat and you take your needle and pull it up to the ceiling, you're going to see white around the needle. If you see gray, you're too superficial. And if you see nothing, you're too deep. So you want to keep it the same depth throughout. That's what's going to give you that flat, beautiful upper lip look. You don't want to have different depths. That's what's going to give you those hills and valleys in the lip, if you will. So you're going to go all the way down to the wet, dry border of the lip. I don't inject down here. If you inject all the way down there, you're going to get little bumps below the lip. So I pull up, and where you see this line going horizontal, that's about where I start to inject actual product. I'm doing a slow retrograde injection. And when I get to the tip of the Cupid's bow, I do a slow bolus. I'm also keeping the needle flat and pulled back against that border of the lip. Typically, I'm doing about 0.2 mLs in this injection spot. I don't really look at how many mLs are going in, but typically that's what goes in, about 0.2. It's different for everyone, but that's what's pretty much happening. Second injection is going to be right next to it, the other side of the Cupid's bow. I'm just trying to exactly match what I did in the injection number 1. Again, that's about 0.2 mLs. The third injection is where injectors have a little bit of trouble with, but once you get it, you've got it. It's almost like riding a bike. Once you figure it out, it works every time. So the third injection, the needle goes into the border of the bottom lip, and you want to make sure here, key is to not bring the needle the whole way up to the wet dry border. This is where you really don't want to create a track that goes up. We want to keep the volume of the lip more going to the side. So if you put the needle the whole way in, it's going to create that track and you don't want your product to go there. So I just pop the border with my needle and I flip the lip over if I can. I do a little bit of an everting of the lip, and while it's flipped over like that, I start to bolus. Again, this is about 0.2 mLs. If you're in the right spot, the product should spread to both of the tubercles and fill the whole border. 50% of the time, I'm completely done after 3 pokes. Other 50% of the time, if they need lateral coverage, I'm very simply doing just a tenting procedure on the lateral part of the lip. If you've watched the previous webinar, I used to come laterally and go medially. There's 2 reasons that I don't do that anymore and I go medial to lateral. One is because they're numb in that area already from your first pokes. And number 2, they get a lot less bruising going medial to lateral. So I go from my first injection, I'm about 1/3 of the way down, and I'm going to just tent or fence, whatever you want to call it, a couple threads of product into the lateral part of the lip. I would say 90% of the time, I'm not injecting any product into this oral commissure area, maybe about 2 millimeters over, no product. I try to put most of the product in between the patient's nostrils. I like that to be where most of the volume of the lip is. That's the main gist of it. If you have questions, write them in. These are some of my lips. You can see I like that 1-to-1 ratio. I like a little bit of a keyhole pout. I like the drama. I like them juicy. This is what we like to call 3-point bolus technique. Is going to create your maximum height and it's still going to look natural but plump and beautiful. These are the before and afters from the before slide as well. Here's a quick injection video of injecting the lower lip with this technique. So you can see the needle, I tried to zoom in here, is right in the border of the lip and it filled both tubercles. And then if you just kind of squeeze it together, it's going to go right where you want it. I'm going to play it one more time so you can see the spread. And then you just take it and just mold it with your fingers, just quick like that. And it just kind of does your job for you. So I've tried this with other products. It doesn't work as well. This product is perfect for this technique because it has spherical particles. It's the perfect amount of cross-linking to be able to spread and fill the lip for you. So it kind of follows the patient's own anatomy. So instead of trying to create a different lip for them, we're giving them their volume back to where it really should go. I don't typically numb the patient. I don't like numbing cream. But this is going to give you crisp borders without doing a lot of work. It's going to define the Cupid's bow, and it's letting the filler go where the lip wants it to go. A quick video of the first injection for the top lip. So we're injecting into the top of the Cupid's bow. I'm pretty superficial, but if you look closely, you can start to see the spread going right across the border. So it's filling the whole Cupid's bow. We're filling more than half the lip there, and then it fills the tubercle. I usually just kind of flatten it out with one little pinch, and then we're good to go. So you can see the height that you can create by doing that just with one poke. I'll play it one more time. I think that's a good video of exactly where the needle should be to get that spread. It's very low trauma. They get almost no swelling. Very rarely do I get any bruising because I'm not putting the needle all through the lip. All right. So this is the first video. This is going to be the full technique on this model. I think I did exactly 7 pokes on her. But you can see the first injection point. We're going right into the Cupid's bow. And I'm slowly bolusing. So you can see that whole tubercle right now filling up with product. If I'm not getting exactly where I want the product to go, you'll see I'll sometimes do an extra fan just to get that extra volume where I need it to go. But I still like to keep it to just one injection point so that it's less trauma for the patient. You can see I also like to take the skin of the lip and I kind of flip it over the needle, and that allows me to get more height, and it allows me to get the product kind of below that skin there so I can get more of a pink show. If I get any little lumps because I'm doing a little bit of a bolus, I just scratch it out with my thumb like you saw there. The third injection point should be at the bottom. So we're gonna go right into the border, right in the center. You can see the lip didn't kind of flip over on its own with the needle. Sorry, that cut off there for a second. So I just use my finger and I kind of flip it over. If I'm not getting the spread, which I wasn't there, I'm just gonna start fanning. So I did 2 or 3 fans here, and you can now see the product is more so spreading, but we're keeping it right at that same insertion point. Now, because most of the product went to that side, probably have to do a little bit more on the other side. So I just moved my angle and I'm gonna fan into that other side there. So you can see how I try to flatten the lip while I'm injecting. It's all retrograde injections, and I'm pulling the lip down to try to create more vertical length for the patient. So now we're going about 1/3 of the way over. So you can see I'm measuring from my first injection point. We're still now in the body, but we're gonna give that lateral coverage. So I did about 4 little fans here, but they're very, very tiny. I'm doing very small amounts of product on that side of the lip. And we're just gonna match it and do the same thing on the other side. Now this patient didn't numb. She's very, very comfortable. The lidocaine that's in the product is much stronger than numbing cream would be. And you can see very minimal bleeding. Same thing on the bottom. So now to fill the lateral part of the lip, I went from that first injection point a little bit of the ways up and over laterally, and we're just fanning. And as I'm coming out of the lip, I'm almost like I'm scraping the needle against the lip so it's down and out. So there's 2 ways you can create volume in the bottom. You can either push down like you're scraping the tissue, or you can scoop up while you're coming out to create more like juiciness. But I prefer that pulled down, more flatter look. So that was the 7th injection, and I think looks like I went back in to probably just create a little bit more height on one side. So after I do the 7 injections, I'll just look at the patient and I'll see, is it done? Is it not done? Do we need to tweak anything? The other thing with this technique is it's very buildable. So if someone really wants high high height of the lip, they really want them dramatic, you can just keep doing this and building it up. It's a buildable product. So you can go as small or as big as you want to go. You can do 0.3 mLs and have it look really good. You can do up to an ml and have it look just bigger, but it'll still look good. So it's very moldable for your patient. You can do really any lip with it. I do all my patients with this product from, our 22-year-olds up to our 80-year-olds. So you can see that took me, I think this video was like a 3-minute video. So very quick, minimal pain, and I think they came out pretty good. Let me know what you think. Like and subscribe. No, I'm just kidding. So that's the basic technique for just a simple lip that just wants a little bit more volume. And then this was her before and after. So you can see that we got a lot of volume. And I'm really happy with that result. Quick tip on no numbing. So lidocaine, topical lidocaine, as you put it on the lip, it's going to vasoconstrict as it sits there, it vasodilates. So you can see the difference between topical numbing and no numbing. Typically, they have so much less bleeding, so much less swelling. I really like the patient's lips to not be numbed. I really hate doing nerve blocks if we can avoid them. I want to see what the lips really look like. I also think that when you numb them, sometimes you see blanching with lidocaine or nerve blocks, and you don't want to miss anything that you need to be seeing safety-wise either. So there's a bunch of different reasons, but I mainly just feel like the patients don't actually need it. I feel like once you start injecting them, they're pretty numb after a couple pokes, and they usually say they're completely fine. So the product that I always use is Reviness Lips. I've been using this product solely in lips for probably 5 years now. It's tried and true. It gives me great results. It's easy to dissolve. So I know I can sleep at night. We have a high volume practice. We use tons of this product and we've never had a huge issue with it. A little bit of differences between this product and other products that are on the market. What I like about it is that the spherical particles that they make it with are smooth round particles. If you look at other products under a microscope, they're going to look like cornflakes with sharp, jagged edges. And if you think about it, if you inject those substances into your body looks at them as foreign objects. So there's going to be more white cell cascade. There's going to be more inflammation, more swelling. Your body doesn't prefer them. Your body prefers spherical particles. So we have less swelling, less inflammation, less issues. I think this technique works so well with it because of the smooth round particles. I think that's what helps it allow it to flow into the lip like it does. I don't really have to do much moving with my needle so that the product just goes where it needs to go. It almost does your work for you. It has the highest amount of HA than any other product on the market at 25 milligrams per ml. And they use less BDDE, which means it's very natural looking. It's very easy to dissolve. What's very nice is that even though it has those things, it's extremely cohesive. So once you put it into the lip, it's not going to move. Once it heals, it's there to stay. It's not going to migrate. It's not going to move. It's going to stay right where it is. That's my main things about the product that I love. It comes in 1.2 mLs. Most patients don't need 1.2 mLs in their lip, so it gives you a little bit of extra product to start to show them other areas of their face that they may be interested, or it can help you with getting them on the right track for facial balancing and showing them maybe starting to see another area if they're scared. Sometimes I'll say, I have 0.3 left, let's try this area. And, then they see it's easy to do and it's going to make a big change for them. Business wise, it's the best ROI that you can get. If you're a business owner, I think you should not be buying many other products if you want to have a good ROI. I like that they have volumetric pricing, which means that you don't have to buy X amount to stay at the price that you're getting. What your price is what your price is. You don't have to buy X amount each quarter to maintain this tier or anything. There's no baloney. It's just what it is. They have tons of training and educational support. Obviously, you guys are here tonight. They do tons of stuff like this to help your business and help you become the best injector that you can be. It's manufactured in Canada, which is nice. It's in North America, so it's local. All right, we're going to get into difficult lips. We're going to talk mostly about the M-shaped lip, and then we're going to get into thin lip. So I know everyone hates the M-shaped lip. M-shaped lips are my favorite lip to treat. These are the patients that typically look in the mirror after and they have tears in their eyes. They're so happy. They've typically not loved their lip shape for a very long time. So these are my favorite patients. The look that they usually get afterwards makes me very happy and reminds me of why we're doing this. So typically they have this pronounced central tubercle that's bigger than the rest of the lip. They have thin, less defined sides, and typically they also have a muscle issue that's going along with it. So sometimes it's not always the lip itself, it's the muscle. So when they smile, the muscle pulls the lip down and in. I usually tell a lot of my M-shaped clients that I won't do their lips unless they do a lip flip with it. And they have to do the lip flip every 8 weeks for a year. We know now through studies that a lot of times once you start to do a lip flip, sometimes you don't even need it anymore. It kind of trains the muscle to stay down. So that's a non-negotiable for me. I tried to show you on here my technique for filling an M shape. The biggest thing is don't put any product at all into the central tubercle. It's already big, it's already defined. You want to avoid that at all costs or it's going to make them look more ducky. What I focus on is creating heaviness right above the deficit of the M shape. So they have this kind of curve here, and the goal is to get that more flat, which will make it look prettier. So I do little micro droplets above the wet dry border, but right above where that deficit is, and that's going to push a little bit of heaviness over that area and hold the lip down to flatten that. So I'm not usually pulling up as much in these lips. I'm focusing more on that lower part of the lip, which is what's completely different than my first technique. I'm usually pulling a lot up. In this one, I'm doing a lot of work down by that wet dry border. So I tell these patients also, because I'm doing a lot of product in that area, sometimes I can't fully correct it in one sitting. Sometimes it takes 2 to 3 for a full correction. But I just don't know until I get started. Sometimes I think I'll need 2 sessions and we end up getting a ton of product in there and it looks really good. But I tell them I won't really know until I get started, but I'll be honest with you and I'll tell you what you need. But typically I warn them it might be 2 to 3 sessions and I try not to overpromise. I always tell them slow and steady. It might take a couple of visits, but we're going to get this perfect and I'll show you how I do it. So this is the best M shape I could find for you guys for a model that came in for this filming. So you can see, I hope, can they see that? There we go. So you can see this fully bigger central tubercle. So I'm going to go in, I'm going to start off the lip exactly how I did it before. So you can see I'm doing a retrograde injection. She also did want a little bit more height and volume. So I'm bolusing here at the tip of the lip. You're going to start to see product spreading. There it goes. So you can see it, that tubercle filling up. You can see we're not going into that central tubercle. I'm going to start to fan a little bit. Now at the bottom of my fans here, I am putting a little dollop of product, which you can't see the full syringe, but I'm doing little micro droplets of product down at the bottom. I pull up a little bit without injecting, and then I'll do the rest. If I want more height, I'll do another retrograde injection until I get to the top of the Cupid's bow. Because they were filming on that side, we went to the bottom. Usually I do the full Cupid's bow first and then go down, but it doesn't really matter. So bottom lip injection is going to be typical injection that you always see me do on the bottom lip. We're going to flip that lip over to try to give them more of a pink show. And then we're going to see if we can get some spread of product. You can see that both those tubercles starting to fill up a little bit. I didn't get as much spread as I wanted to. So you can see I just went about 1 millimeter to the side of my first injection, and I'm just going to start fanning that product. And you can see again, I'm doing that pull down, pull out kind of technique where I'm almost, again, we're kind of scraping the tissue down. And then you can see, if you look at the border, you can see the product spreading along the border there without going in that way. And then again, just take the lip and let it do its thing. Let the product go where it wants to go. And it's going to look more natural that way. Okay, so now we're going to go and fill a little bit more of the lateral part of the lip. So you can see I moved about 1/3 of the way over laterally, and I'm just going to fan. And anywhere I see a little bit of height in the wet dry border for that deficit, I'm just going to keep going down and doing micro droplets of product until I get as much heaviness as I want. But you can see even now how much flatter that wet dry border looks. But that was not a retrograde injection, that was a dollop of product. So I'm only sometimes going in and just doing those little micro droplets. Sometimes I use a piece of cotton if the bottom lip keeps bleeding. That way I can just continue the procedure and let the cotton take up the blood. All right, so same thing on this side. So we're going to go right into the other side of the Cupid's bow. I'm going to slowly bolus at the top here. We're going to see if we can get some product spread. If not, we're going to start fanning. At the bottom here, we're going to do little micro droplets to create the heaviness above the deficit of the M shape. When you're coming out at the tip of the Cupid's bow, another little pointer is to continue to inject product. So you see a little dollop of product outside of the lip. That's going to also help you create a little more height there. So I'm just continuing to do these micro droplets. If she needs more height there, then we'll do more retrograde injections. Now we're going to go lateral. So you see I went 1/3 of the way down. We're going to fill the lateral part of the lip with just a little bit of fanning, small retrograde, thin threads of product there. So you can see again, patient's extremely comfortable. Now we're going down. I see a little deficit where the M shape was. So now you can see I'm going to be doing micro droplets in the wet dry border. Because I'm down by the wet dry border, I try to not put too much product there. And if I see any little bumps, I'll just start to scratch it out. And I will just keep going in and doing this, the micro droplets, until I get that as flat as I can get it. Okay, looks like we're done. So I usually use a little bit of arnica. I cover the lips with arnica when I'm done, and then I usually use my fingernail and I just feel if there's any little lumps and bumps that I need to scratch out. So that's her after. You can see how much better that wet dry border is. It's flat and we've lost that M shape now. So if you look together at the before and after, I want you to look at where you see this defined central tubercle and how the lip goes up. And now when she smiles, it's completely flat. So that's the goal with the M shape. So treating a thin lip, this is the vein of my existence. No, I'm kidding. I love a thin lip too. I like doing more difficult lips. I just feel like I like a little bit of a challenge. But basically, thin lip is going to be less volume, less defined vermilion border. They're going to be narrow, flat. This can be genetic or it can also happen in the aging process. So I'm going to also show you a quick thin lip. This should only, I think this video is only a few minutes also. Yeah, it's about a 3-minute injection. So you can see how thin these lips are. I had her smile and try to move her mouth around a little bit so you could see what we're doing. The only difference I'm going to do with a thin lip is that I'm not going to be bolusing as much on top. I don't want to create this ducky, big, huge lip for her. And again, sometimes these thin lips will surprise you and they can take more product than you think they can. And sometimes I can do 0.3, 0.4 mLs and I'm in a good place. It just depends what their anatomy can handle. So instead of bolusing, you can see what I'm doing here is just doing fanning. And I'm just doing thin amounts. And I'm going to try to cover that whole border by just doing the body. So you can see we get kind of a pop of the border, but I'm not injecting anywhere else in the border. We're going to do the same injection on the bottom. Now, I usually try to bolus and see if I can fill it. We'll see if it goes here. And it is. So you can see it's actually filling quite nicely with that one injection. So now you can see it going all the way to the side. And then I'll start to fan if I need to, but that actually worked pretty well there. So hold back the lip so you can see where you want to see it. Again, I'm taking that skin and I'm kind of pushing it over the needle. That's going to give you more of a pink show of the lip if you inject while the skin's kind of over the needle like that. A little bit more of a lateral coverage there. And really, you're just looking at the lip, you're assessing the whole time. With these thin lips, you just want to make sure you're not overfilling, I think is the main tip I could give you. I think less is more. If they need, extra product, I usually tell them to go home, let this fully heal 2 to 3 weeks, and then come back. We can always do more. So same thing on this side. We're pulling up and trying to give her some height here, seeing if we can get some spread. We're starting to go down that side there. And then we'll just fan to make it look a little more even. Now we're going to go about 1/3 of the way down. You can see where we filled with the first injection. So we just go a little bit lateral and we're going to try to fill the lateral part of the lip in. And we just look and continue to correct as we need to. This was definitely one of the more difficult lips I've done. Her lips just didn't really want to take the product, but she was thrilled afterwards. So, and I want to say, I think we ended up using 0.7 mLs of product, but I did it quick. I just did about the seven injection points. And then when you put the before and after together, it was, she was a little swollen from the injections, but that was her before and after. This is a thin lip before and after I like to show a lot. I usually ask people in my training, how many syringes do you think this took me to get from this to this? This actually took me 5 syringes over 1.5 years to get her to this mark. So I tell people with really thin lips, we can get you there. It just might be a little bit more sessions. So they have to kind of be ready to do multiple syringes usually, and it might take over 1 year. This is an uneven asymmetrical lip. I also like to show this. This patient came in, this is her natural lip. She had no filler in the before pictures, believe it or not. I actually didn't inject the right side of her lip at all. All I did was I went in on the left lip, which was lower, and had less volume. But what I want to point out is that her left upper lip is curved and the right upper lip is straight. And if you have someone that has that, you can actually fix that. So you can see in the after, they're both straight. What I did was I went in at the Cupid's bow up here, the needle comes down, and instead of pulling straight up, you're going to curve your needle almost like a scoop, like a U shape, and you're going to scoop it this way and up. And if you think of physics opposite force, it's going to actually take that roundness and flatten it when you pull up. So you can actually fix that for people, and they think you're a magician. So that's a cool thing I like to tell people. Aging lip, I'm not going to show you a video of it. I do it exactly the same as the thin lip that you saw, but keep in mind, lips flatten, they start to get perioral rhytids, their oral commissures droop and downturn, they're going to get marionette lines. We have flattening and fading of the philtrum column, Cupid's bow droops, and we lose definition in the vermilion border and Cupid's bow. So usually a tiny bit of filler in these patients goes a long, long way. They're very happy with just a little bit of hydration. Don't overfill them. The biggest thing I love to do now is take a lip and instead of just injecting their lip, do a full face assessment on them, because for a patient like this, if she came in asking just for lips, I think that would probably look a little bit silly on her. So if you look at the bottom, we actually did a balancing all around the mouth with Versa, and this was the result that she got. So you can see how much better this looks and how much more natural she looks, rather than if I just plumped up her lips a little bit. She needed the balancing around it. So lip framing is really the new lip magic, I like to say. It's hard for me now to do a lip without looking at the whole face and making sure the whole face is balanced around it. So we sell packages that get people into these so that they can purchase a package to get their full lower face kind of treated instead of just the lip. So that's a whole nother story, but we don't have time to get into it. Overfilled lips, just dissolve them. We don't need to treat this at all. We're just going to dissolve. I know we're running out of time, so we're going to go quick here. The poorly filled lip, this is the result of superficial. So if you're injecting and you see gray, when I said you need to see white, if you see gray, this is what can happen. The product can go too superficial and you can end up with these bumps. This is a Tyndall effect in the lip. Again, just dissolve it, or you can pop it with like an 18 gauge and just squeeze it out like a pimple, and it's very satisfying. Another hint, I know we only have a couple minutes left. When you have a previously filled lip, the lips can actually acquire a plane that is really hard to close. So remember, even if you dissolve someone, if you've had someone get filler and the needle went in and they bolused product and retrograded it out, like this top picture, say this is where the needle went and the filler was sitting here for a year, it's very hard for that track to close. So then if you went in with my technique and went in from this part of the lip, when I want it to go a certain way, you might start to see it spread up here. And you're like, why is it doing that? It's because they've had a previous track placed. So always remember that. Hylenex, we're going to flutter spot dissolve. We add 0.1 of Lido and 0.2 of sodium bicarb. And you can flood the area where there's filler. You can spot dissolve above the lip. Hylenex is very acidic, so add a little bit of sodium bicarb and it'll take the sting away, and your patients will love you for that. I'm quickly going to go over vascular occlusion. I'm really just going to kind of give you my protocol because we don't have time to go through the ins and outs of it. But obviously we want to know what to do in case we do have one. But these are all examples of vascular occlusions in the pictures. They can present in different ways. If you get to the bottom left picture, that's more late onset, what's going to start to happen. So you want to catch this early, but know your anatomy, inject slowly, inject small volumes at a time. And you want to use a lower G prime filler like Revanesse lips. It's going to have less intrinsic pressure on the vessel. So the thicker G prime fillers are at more risk of having a compression occlusion. So you want to use less of a lower G prime filler. You can take a picture of this. That's fine with me. This is our current vascular occlusion protocol that we use in our office. This is research backed. This is the current, what they recommend currently. So you're going to stop your treatment, check your cap refill. You're going to massage the area. We keep heat packs in our office that you can just pop and put on people if you're worried you want to put heat on it. Tapping, if you tap over an artery that's clogged, it can sometimes dislodge the emboli. Flood it with Hylenex. We keep at least 16 vials in our fridge at all times. Make sure you have a lot in case this ever happens to you. The current recommendation is giving aspirin 300 milligrams, then 75 milligrams daily for 5 days after to keep the blood flowing. We cancel clients in our clinic for 2 hours. We want all hands on board. This is a medical emergency. It can be catastrophic. We don't take it lightly. Biggest advice I can give is be very honest with your patient. They will appreciate it. Tell them what's going on. Make sure they know you know what you're doing and you are appropriately ready to treat them and take care of them. Later down the road, antibiotics and hyperbaric oxygen if needed. That's all I've got for you guys. If you guys have questions, okay, I think we have 10 minutes for questions. So they've been, okay, questions are rolling in. All right. Okay. So I'm just going to go right into these questions. How do you consult on the multi-treatment approach? What's the best way to educate patients that they will need multiple treatments to get their goal? And do you price this? So, great question. I think you have to do what's appropriate for your area and your practice. For me, personally, I'm very, very honest with my patient. So I would rather under promise and have them not be upset with me. So if I think that they come in with a lip that's going to need multiple treatments, I'm very, very honest with them. I think that's the most important part. If I think I could do it in 2 sessions, sometimes I'll say this might take me 3 to 4 sessions. That way, if you do it in 2, they're like, oh, she's great. Pricing, I charge at this point in my career, I charge the same every time they come in. Now, if it's a patient that's been with me for 10 years and she's getting not a full syringe, I will price it lower, but typically they're paying for an outcome. They're not paying for the amount of a syringe. So our practice as a whole has gotten away from talking about syringes. We're selling just an outcome. So whether it's, you know, your 80-year-old lady who comes in and needs 0.3 mLs or your 22-year-old patient that comes in and wants the whole 1.2, it's the same price. It's just a matter of what they need to get them to the result that is going to look best for them. I hope that makes sense. Next question was, what's the Canadian equivalent of lips? That's going to be Ultra. And I was just in Canada a couple days ago and we did a training and they use a lot of outline also in the lips. And it was a beautiful, beautiful product. It's a little bit thicker. That's good for like a border, but the equivalent of what I'm using is going to be your Ultra. Next question was, do you aspirate with each injection and when are you fanning? In the lip, I don't aspirate ever. I stay very superficial. So I don't think there's a need for aspirating. I fan in 2 situations. So the first fanning is coming at the Cupid's bow if I'm not getting the spread of the product where I want it, which can happen just based on anatomy, or it can be that they were previously filled and the filler is kind of stuck in there somewhere and you can't get past it. So I'll just start fanning. The second fan is for the lateral coverage. So I'm fanning to get the lateral coverage, very, very thin amounts of product. Next question, does your technique work for previously filled lips as well? Yes, it does. You just may not get the beautiful like spread of the product, but you can still, I still do it on people that have filler in there. Okay. Next question, do you use any other product for structural support in the lips or strictly lips? So personally, I only use Revanesse lips in a lip. I think I'm just to the point where I haven't used another product in the lips in probably, I think like 5 years now. So I wouldn't even be comfortable like pushing another syringe. I feel like I can use this product with my eyes closed. So I'm very comfortable with it. So I don't personally use anything else, and I have tried to do it to see just if the technique works with other products on the market, and I can't get as good of a spread. So I do think it's because of just how this product is manufactured and the spherical particles, that it spreads like it does. So you can do just a few injections. Okay. Next question was, when you're fanning, are you slowly injecting product as you're pulling your needle out? Yes. So when you're fanning in the lateral part of the lip, when you put the needle in, you're doing a retrograde injection and you're injecting product as you're pulling out. And I do very, very, very thin threads of product. So typically I'm doing anywhere from 2 to 4 fans, and it's tiny, tiny amounts of product. I probably for a lateral lip wouldn't go over about 0.1 mLs in each lateral lip. Okay, next question. How do you prevent spread outside the vermilion border? So the only places that I will put a needle through the vermilion border are the tips of the Cupid's bow and then the center of the lip. The biggest key is that you don't want to inject product into the white roll of the lip. You want to go over the white roll and inject into the pink. That white roll is kind of like a border or a fence that's going to keep it from coming out. I think the biggest mistake and why we've seen so much migration over the years is that people were doing so much so much tenting across the whole lip that they were poking through the border, and we were creating all these tracks, and the filler could just come right out of the track and it was coming outside of the lip. Also, using a product like this is what's going to help you the most because it's more hydrophobic. So if your patient has a different product in them that's really hydrophilic and they go home and they eat a salty meal, or they're traveling, or they're sick, for any reason their body's retaining fluid, their filler, if it's not this product, if it's a hydrophilic product, and it's going to swell when their body's retaining fluid. And if they've had all those tenting threads through the border, the product is going to swell and has nowhere else to go other than outside of the lip. So you want to use a more hydrophobic product. So with this product, it's the most hydrophobic product on the market. That's what you want to put in a lip so you don't have issues like that. Next question, I think this might be the last one. Can you elaborate on the bottom lip injection with your technique? Is this an insert? I think she says bolus method. Okay, so the bottom injection, I'll go back and play it again for you. Here it is. So you can see the needle. So I go in right at the bottom. I'm only popping the border, I like to say. So you don't want to go in the whole way. If you're in the right spot in that lip, in that border right there, it's going to fill the entire bottom lip. So it's going to fill both of the borders going both directions, and then it's going to fill the tubercles. Filling of the tubercles is more so happening because the product is like the perfect like thinness and smoothness that when you go like this, it just goes right into place where it needs to go. The key is, again, inserting the needle onto the pink part of the lip and avoiding the white roll, and just keep practicing it. And once you get it once, we see it in trainings all the time. Once you get it, you've got it. It's like riding a bike. I think we are out of time. If you guys have questions, you can still send them. I'm going to ask Robin where you guys can send them to. You guys can always DM me also. It might take me a couple days to respond, but I will look at your messages in the next couple days and try to get back to all of you. But that is all I've got for you. Thank you guys so much.
Thank you, Heather. Like Heather said, I know she's always happy to connect. You can also reach out to Prollenium Medical Affairs, or you can reach out to both. I know we have many, many questions we didn't get to, so please feel free to reach out. Heather, thank you again for joining us tonight, and thank you to all of you for attending. After the webinar ends, there will be a survey sent around. The recording of this will also be available in the coming weeks, both through your Prollenium rep and sent out to all webinar attendees. So keep an eye out for that. And in the meantime, reach out to your Prollenium sales rep if you have any questions. Thank you all so much and have a wonderful evening.
You guys.